Bismillahirrahmanirrahim. I'm Professor Wael Lotfi, Professor of Pediatrics, Pediatric Cardiology at Cairo University. I'm introducing my invention, which is called line balloon mounted stent. What is this invention? How did I get the idea? And what does it do? How did I get the idea? I got it from the operation of pulmonary artery bending. It's a surgical operation. It's done by open thoracotomy or sternotomy, and sometimes by laparoscopic thoracoscopy. This operation has not been very successful, with unacceptable mortality and unacceptable morbidity. Morbidity because it's difficult for the surgeon to estimate at the time of the surgery the amount of the band needed, the amount of the stenosis needed to create. So I was thinking and developing a catheter form, an interventional catheter form, to perform the same procedure without the need for open surgery, particularly for those patients, infants, babies, or children that are unstable and cannot tolerate this operation, together with a mountable success rate. This intervention is done by catheter, interventional catheterization, where I introduce a balloon catheter on which there is a mounted stent. This mounted stent has a line balloon, and here is the name, line balloon mounted stent. And after introduction of the stent at its place, for example in the pulmonary artery, the balloon is inflated, the stent is in place, and the other lining balloon of the stent is inflated like a tire in a wheel, producing an adjustable stenosis of the pulmonary artery, and thus can be controlled and can be evaluated during the procedure itself. And the procedure itself is a one-day procedure. Can be done at the cardiac catheterization lab with minimal costs, higher accuracy, no expected mortalities, no expected morbidities. The adjustable criteria can be, the stenosis can be increased, can be decreased, without referring to surgery again, and with a much lower cost than the surgery and the hospital stay of the surgery. This same invention can be used for occlusion of open channels, vascular channels, as an example. For example, the patent ductus arteriosus, with a much less cost than the competitors, and being a stent, it's the technique that is used by interventional cardiologists. No particular need for special learning of the technique, and again we don't produce stenosis outside the vascular channel that is needed to close or occlude, and again the occlusion is complete, not incomplete, with residual flow across like produced in the coils that we see. This invention will reduce the costs, and it will be easy to apply, and it has multiple versions with multiple designs having the same idea: a stent that's being placed in the intended vascular channel or other channel, and the ability to either adjustably stenose or totally occlude this channel. Again, in the event of total occlusion of the channel or partial occlusion of the channel, and let's say after a month or a year this stenosis is not needed anymore, it can be relieved easily by another interventional procedure that is non-risky at all. The regular stent, medical stent, as introduced from usually any of the venous inputs, for example from the femoral vein, usually as introduced from the right femoral vein, traveling across the inferior vena cava, through the right atrium to the right ventricle, and across the pulmonary valve to be placed in the pulmonary artery, the main pulmonary artery. Here, after making sure that the stent and the catheter is in the right place, we'll just position the stent by inflating the balloon catheter. After making sure that the stent is well placed and in the right place intended, then we can deflate the balloon catheter and inflate the stent balloon. The stent balloon, like a tire in a wheel, will reduce the size of the lumen of the pulmonary artery, and this is adjustable so that it will reduce it and we can measure it at the same time. We have our balloon catheter tip at the distal pulmonary artery, and we can have another or the same catheter in the right ventricle to measure the pressure gradient. This can be done as well with a transthoracic or a transesophageal echo at the same time to measure the gradient across the pulmonary artery. Again, we can measure the cardiac output and the ratio between the pulmonary and the systemic blood flow before releasing the stent totally with its lining balloon. After making sure that we have the maximum parameters, the maximum beneficial things that we need, we can just withdraw the catheter, dislocate it from the stent and its lining balloon, and withdraw it regularly without causing any problems, without surgical scars, without prolonged hospital stay, with a minimal cost. And again, it can be revisited by interventional cath in the event that this is needed. Why this is? Because this lining balloon can be inflated with just CO2, it can be inflated with any liquid, and it can be inflated with a viscid liquid, so that it can be preformed to particular shapes. At the same time, this lining balloon stent can be introduced to an open vascular channel that is needed to close totally. In the example that I was just mentioning, we can just continue with the catheter to the patent ductus arteriosus from the pulmonary artery, and of course the patent ductus arteriosus can be approached as well retrograde from the aortic side, retrograde left side catheterization. And then after placement in the patent ductus arteriosus, the balloon catheter is inflated, placing the stent at the right place in the patent ductus arteriosus, and then deflating the balloon and inflating the lining balloon of the stent, producing a total occlusion that can be verified during the catheter or by echocardiography. And then if we are happy with this position, happy with this total occlusion, we can dislocate the catheter and remove it, and the procedure does not bear any shoulders that are either on the aortic side or the pulmonary side. We are not stenosing any of the main vessels, only the wanted open vascular channel, and it can be applied for cerebral fistulas, cerebral arteriovenous fistulas, aneurysms, and anywhere in the gastrointestinal, urological system with the same technique. The line balloon mounted stent invention was first presented to the WIPO on September 2003. It was published on March 2005. The European patent registration confirmation was on 2009, and the Japanese patent was procured on this year, 2010. My other published inventions include the valve balloon mounted stent. This invention was first presented to the WIPO in 2003. This invention idea is about a valve that is introduced by interventional catheterization through any of the venous sites, and the valve is placed on a stent, and the idea is that the valve is in the shape of a cage. The cage is the stent, and there is a ball inside, a cage and a ball mechanism, where the stent is put at the intended site of the valve. The inflation and positioning of the stent crushes the original damaged valve, in case there was one present, and the ball introduced at the deflated side is inflated and function as a ball and valve mechanism. And this can be done with a smaller size. It does not need to be big like the interventional valves that are produced at these days, and at the same time without all the complications and the costs of the surgery. Can be done for unstable patients, can be done for young patients, it can be done with smaller size infants without problems. My other invention is the perfusion balloon catheter that was introduced to the WIPO in 2007. And this perfusion balloon catheter idea is about dilating stenosed vessels, valves, without producing total occlusion of the flow during the process of dilatation. For example, when dilating the pulmonary artery or the pulmonary valve, we are not occluding total cardiac output and compromising the patient. The idea is like a tire in a wheel, and while dilating the stenosis, the flow is still continuous. There is no peripheral ischemia. There are no high pressures proximally, no arrhythmias. The position of the balloon is more stable, and this balloon can come, of course, with an overlying stent. For example, while dilating the coronary arteries, during the same process of dilatation, there is no need to produce peripheral ischemia with its associated risks. And thus, we produce the same concept of dilatation, but with much lesser risk, more stable position of the balloon and the stent if the stent is needed at the same time. Thank you.